So this course includes a lot of different things. Antibiotics is where I think I'm going to really start with most of the meat of true medications. I think that it's where almost every specialty uses a lot of antibiotics. They're used a lot in the hospital, they're used in outpatient. So I think we'll spend some time on that. I do have a number of other videos made by other people that are on the playlist. I don't think there's any sense of reinventing the wheel. I'd really appreciate your thoughts and critiques of those. There may be duplication. Duplication in and of itself is not a bad thing because sometimes it just reinforces things. I'm going to fly through these slides, give you some foundational information, and then we'll watch some of the other videos, and we'll also discuss a lot of this stuff on the discussion boards and then probably in class as well. So we'll start. I always like to start with a case. MARIPAT is a 66-year-old woman. She has an open area on her foot. Her husband died 6 months ago. She's diabetic and has been for 8 years. And she's getting ROCEPHIN 1 gram every 24 hours. I really like to start with a case because it puts into context the fact that when you're giving a patient a medication, you're giving a person a medication. And so MARIPAT is 66. Why is that important? Well, she probably has Medicare. She's probably less worried about paying for these things than somebody who was 62 or 63. She's diabetic. She's going to have a harder time healing and a harder time fighting off infections. So we're also going to try to get her diabetes under good control so she can fight off the infection. Her husband died 6 months ago, so she's got some stress from that, as well as the fact that she may not have a lot of support at home as far as getting her medications and taking her medications. So what is infection? Infection is when a bacterial growth is causing problems for the organism. Colonization is when there's a growth of bacteria. So you may have colonization in your armpit. There's normal flora that colonize your mouth. The vagina is colonized with a number of different bacteria. It's only when they overgrow and they start causing inflammation and problems for the organism that we consider it to be an infection. The chain of infection. There's 3 major areas that we can affect the chain of infection. We can affect the host. We can make them stronger. We can give them immunizations to keep them from getting infections. We can affect the agent. We can kill it with antibiotics. We can antiseptic areas and clean. Or we can stop the root. We can make sure that people clean things before they swallow them. We can make sure that catheters are intact. Those are the 3 places that we can really impact infection. So going back to MARIPAT, what can we do? Well, host issues. Yes, she's diabetic. We have to make her healthier. Environment issues. We're going to make a very clean environment for her. We're going to make sure that her foot is covered. And we're also going to make sure that the organism is sensitive to the ROCEPHIN so that we're giving her the right antibiotic. So hospital-acquired infections are obviously something that is of great concern to all of us. We used to call them nosocomial infections. We don't usually use that term anymore. But basically, if we wash our hands, if we are very careful and don't cross-contaminate, we will hopefully prevent hospital-acquired infections. Obviously, you'll learn more about this in your other courses. Lots of times these infections are harder to treat because the bugs are more resistant. A lot of these patients have had antibiotics, and so you may have selected out a much nastier infection. This is one of those ironies where if you have somebody that's really sick, you put them in the hospital, but the problem is that the hospital is the place where the nastiest bugs are to cause the worst infections. So if someone isn't that sick, they're generally much better off not to be in the hospital. So let's do a little bit of a review of microbiology. So there's lots of different types of organisms. Bacteria have a cell wall, not a cell membrane. That means they're in the plant kingdom. They can either be anaerobic or aerobic, whether they breathe oxygen or not. And they can also be gram-positive or gram-negative. So if you have a bacteria, you're going to look at the shape of it, whether it's a rod or a cocci. You're going to look at the gram positivity or negativity. And anaerobes and aerobes are hard because anaerobes just don't grow out in cultures, just because almost all the environment that we're dealing with is going to be oxygen rich. So mycoplasma are interesting organisms because they're sort of halfway between a bacteria and a virus. We sometimes call them atypical bacteria because they lack a cell wall. Mycoplasma pneumoniae, chlamydia pneumoniae. There's a number of different ones that fall into that mycoplasmal category. Viruses are sort of parasitic. They have to live in another cell. They do reproduce and pass along, but to really thrive, they need to be inside of a person or an animal or some other organism. Chlamydia is a type of mycoplasma, usually, or atypical bacteria. Rickettsia are specific types of organisms. We don't see them much. There is more interest. Rocky Mountain spotted fever is caused by a rickettsia. They're a lot harder to grow out. Fungi are basically yeast and fungal infections. And then there's some other type called mycobacteria. It's very confusing because mycoplasma are halfway between a bacteria and a virus. Mycobacteria are sort of halfway between a bacteria and a fungus. And the most common or most notable mycobacteria, of course, is Mycobacterium tuberculosis. Parasites are different than any of these others because they have a cell membrane, not a cell wall. And so even one-celled parasites, such as protozoa, are thought of in that parasite category, but so are worms and mites. So as we say, this is really kind of a brief review of microbiology. Things are either gram-positive or negative, cocci, rods, and spirochetes. So what does the body do when infection happens? Well, the first thing that the body does is it tries to maintain intact skin. It tries to avoid being exposed to infection. But once the bacteria or other infective agent has entered the body, we create an inflammatory response. There's sort of a non-specific response because the white cells will jump in and try to attack this attacker. There's really 6 major types of white cells: segs, bands, lymphs, monos, eos, and basophils. We'll talk about those when we talk about more infection stuff. There's actually a lot of that on the blood count. If you go on my YouTube channel, there's really a good talk, which is a little bit outside of the idea of pharmacology, but it really does talk about how to look at the differential. The immune response is a more specific response. So this is basically when you have an antigen, like a virus, the body creates some kind of an antibody to that. And so if you have the measles, you create an immunoglobulin specifically against the measles. And we can test those in the blood. So let's go back to the white cells a little bit here. As I say, there's a lot more on that blood count video. There's segs, which are immature polymorphonuclear leukocytes. Polys are confusing because polys can be called polys, they can be called neutrophils, they can be called PMNs. There's a lot of different things that they're called. But basically they are the white blood cells that protect us against bacterial infection. Bands are when the polymorphonuclear leukocytes are immature. They only have one little band around them. And so in acute infection, lots of times the body will pump out a lot of bands. The other name that you'll often see on a blood count now are IGs, or immature granulocytes. There's three types of granulocytes. There's neutrophils, which take a neutral stain. There's eosinophils, which take a acid stain. And then there's basophils, which take a basic stain. But because eosinophils and basophils can go down almost to zero for their norm, really when we're talking about granulocytes, we're really talking about these polymorphonuclear leukocytes. This is a really important concept because when we get to some of the psychiatric medicines and some of the other medicines, they'll talk about something called agranulocytosis. And basically that's just when the polys go down so low that the body can't fight off bacterial infection. So you know more than a lot of practicing folks do at this point if you understand that. Lymphs fight off viral infections, monos fight off chronic and some cancers, and EOs fight off worms and wheezes and weird diseases. So again, when we look at the immune response, the immunoglobulins, there's 5 basic types of immunoglobulins. But for infection, we're mostly worried about the IgM and the IgG. The IgM goes up with acute infection. The IgG goes up once you've recovered from that acute infection and you're trying to remember what these antigens look like for the future. So if you're looking to see if somebody is immune to something, you check their IgG level. So how does the body respond to different types of infections? Well, for bacteria, we get an inflammatory process. The skin gets red, it gets swollen, it gets hot. And what happens is the bacteria are irritating the skin, and all of these cytokines, these substances that are trying to attack white cells or tract white cells, start to be secreted. Viral infections tend not to cause that inflammatory, that red hot swollen thing. It really is they attack a certain organ or they attack the overall body, and it really depends on which type of virus it is, what the response is going to be. Obviously, if it's a brand new virus to you, you're going to have a pretty substantial reaction. If it's a virus that you've seen before, or a virus that you've seen something like it before, your body is not going to react anywhere near as much. The smallpox vaccine is an example of that. So they couldn't inoculate people with smallpox, so they inoculated them with a virus that was a lot like smallpox called cowpox. And so basically, by having had the cowpox, people would have a much milder reaction if they were inoculated with the smallpox virus. So how do we know if somebody's got an infection? Well, we look at them. Obviously, if it's a bacterial infection and it's caused inflammation, we can also do some blood tests. We can look at the blood count. We can look at the erythrocyte sedimentation rate, or SED rate. Lots of times now, pediatricians and some others are using the CRP, the C-reactive protein, to see whether there's inflammation. Basically, those two tests are pretty similar. There's some subtle differences that we'll learn as we go along. CNS stands for culture and sensitivity. So basically, you take the bacteria, you try to grow it out in the lab, and then you put it into little pools of antibiotics and you see if the bacteria dies. Then by doing this, we can actually see which antibiotics work best for a particular infection. X-rays, of course, will show us if somebody has pneumonia. They'll show us if there's signs of infection in the bone. If it's an advanced bone infection, early infection won't show up. So what's the SED rate? It goes up with any inflammatory process. So it goes up with infection, but it also would go up with rheumatoid arthritis or polymyalgia rheumatica, or any one of a number of different things. So these acute inflammation indicators tell us just that. Infection causes inflammation, but it's not the only thing. CNS is just what we said. So basically, you can take a sample. If you want to know right off what's going on, you can do a gram stain. So basically, they'll identify, is this a cocci? Is this a bacillus? Spirochetes really can't be seen on gram stain because they don't take the stain and they're much harder to see under the microscope. But, you know, we'll say, okay, it's a coccus. Then they stain it. If it takes the stain, it's gram positive. If it doesn't take the stain, it's gram negative. Normally, the gram negatives are harder to kill because they have a much thicker cell wall, and that's why they don't take the stain very well. And sensitivity, as noted, we test the bug against a bunch of different antibiotics. So MARIPAT had a gram-positive cocci on her gram stain. The CNS obviously will come back later. The CNS is back now, and it showed Staph aureus. So all gram-positive cocci are almost always either staph or strep. Staph is a very common bacteria that exists on the skin. Staph falls into two major categories: good old-fashioned regular staph, and then methicillin-resistant staph, or MRSA. MRSA is something that's of great interest because it's a lot harder to kill, and there is great interest in trying to make sure that these more resistant infections don't spread. You're going to see lots and lots of people with MRSA. It's actually a pretty common infection now, and we do have a number of different antibiotics that'll work fairly well for it. MARIPAT sensitivity showed sensitivity to nafcillin, ceftriaxone, and ciprofloxacin. Nafcillin and methicillin are basically the same medicine, and the only way to know that is to memorize it. And so we can use just a regular traditional approach to her Staph aureus. Ceftriaxone is a nice choice because it's a once-a-day medicine. All the others are actually usually more than once a day. Floxacins are also known as quinolones, and we'll talk a little bit more about those, as well as I have a couple of other YouTube videos from other sources that will talk about that as well. So let's talk about some of the specific families of antibiotics. So first of all, let's talk about the characteristics. So bactericidal kills antibiotics. Bacteriostatic stop them from reproducing. So basically it's like birth control for bacteria. Bacteriostatic are going to obviously work a lot more slowly. Because it isn't as aggressive, they often don't have as many side effects. My own observation, I don't know that you'll find this anywhere in the literature, but my own observation is that the bacteriostatic antibiotics tend to have less problems with developing resistance, but I'd be fascinated if anybody finds anything, documentation of that. One way that an antibiotic can be bacteriostatic is that it can block folic acid so that bacteria can't synthesize new proteins. The sulfa drugs, things like Bactrim, which a lot of you may have heard of, may have been on for a urinary tract infection, and tetracyclines also do this. Most common tetracycline we use is doxycycline. Tetracycline was a 3 or 4 times a day medicine. Doxy is really just a twice a day medicine, and so therefore we use that more. So MARIBET's ROCEPHIN, why are we using ROCEPHIN? It covers the bacteria, it's once a day, it's not going to strain her kidneys, it's a good choice for her. So it's a great choice for skin and skin structure. A lot of antibiotics don't penetrate certain tissues very well. Ceftriaxone works great for skin and skin structure. It covers most gram positives and even some gram negatives. Therefore, it's a great option. It's not metabolized. It's basically just taken in and then excreted through the kidneys. And it has a half-life of 5 to 10 hours. And because of the fact that it'll still have a fairly substantial amount of the medicine left 24 hours later, we often do it once a day. So aminoglycosides are an example of a bactericidal antibiotic. Unfortunately, aminoglycosides can also kill human tissue, kidneys, and even ears. That's why you see people from years and years and years ago that had streptomycin, which was kind of an aminoglycoside that damaged the hearing and kidneys. So again, we'll definitely learn these drugs in families. We know the difference of a classification. Antibiotic is a classification. Families are penicillins or aminoglycosides. So the penicillins are good for gram-positives. They're not terribly good for gram-negatives. Interestingly, when they first came out in the late 1940s and early 50s, they were actually pretty good for gram-negatives, but the bacteria developed resistance to them pretty quickly. They learned to create something called penicillinase, and so basically they broke down the penicillin. We actually have kind of outsmarted them now, and what we do is we add something called a beta-lactamase inhibitor, and so penicillinase is a type of beta-lactamase, and so by inhibiting that, we can actually make the gram-negative bacteria sensitive to penicillin again. And so Augmentin's the most common one. That's the oral one. Unicin is actually an example of a penicillin and beta-lactamase inhibitor that's given intravenously. So what about penicillin allergy? It's amazing how many people say that they have an allergy to penicillin. The challenge, of course, is that not everybody really does. Some people, you say, what's your reaction? And they say, well, I never really had a reaction, but my brother had a reaction and my mother told me to tell people I was allergic. Or they say, well, I don't really remember, but my mom told me, I think I might have had some hives when I was little. Now, the problem, of course, is that lots of little kids get hives for all sorts of different reasons, possibly unrelated to antibiotics. The true rate of penicillin allergy, depending on who you talk to, is somewhere between 1 and 11%. The challenge is that you just never know. If someone says they had a type 1 reaction, anaphylaxis, swelling of the throat, difficulty breathing, don't ever try to give them a penicillin. If a physician orders it and they say they had a type 1 reaction, you need to refuse to give it, call the nursing supervisor, do whatever you need to do, invite the physician in to give it himself, but you will be held responsible. You are responsible for any medication you administer, even if the physician has ordered it. If it's an inappropriate order, you're responsible for it. If they had a lesser reaction, a little bit of a rash, a couple of hives, you might be okay to try it, but you definitely want to have some Benadryl on hand in case they do have a reaction. So the cephalosporins, there's really 4 generations of cephalosporins, and one of the other videos will actually cover that. The first generation that came out was really good for gram-positives. Second generation was almost exclusively good for gram-negatives, and we really don't use that one much anymore. Third generation were the long-acting ones that had both gram-positive and gram-negative coverage. And then the fourth generation are really sort of, big guns. These are things we save for really sick people. There is a cross-sensitivity with penicillin and cephalosporins. Depending on who you talk to, it's somewhere between 2 and 15% or so. The challenge is that if you have somebody and you really want to give them a cephalosporin and they say they're allergic to penicillin, again, if they had a type 1 reaction, I probably wouldn't do it. If they had a lesser reaction, you really might want to consider doing it. All antibiotics can cause pseudomembranous colitis, also known as a C. diff or Clostridium difficile infection. So you want to watch all antibiotics to see if people get diarrhea, but certain antibiotics are more likely to do it. The penicillins with the beta-lactamase inhibitors are very likely to. The cephalosporins are likely to. Clindamycin is very likely to. So just watch very carefully for these kinds of reactions. Macrolides. Macrolides are great medicines. They're bacteriostatic. Erythromycin was the original prototype, but everybody in the world got nauseated with it. We therefore developed a better medicine called azithromycin. The problem with azithromycin is that it has pretty good gram-positive coverage, but it's actually started to develop a lot more resistance to one of the very common gram-positive infections, which is pneumococcus or Streptococcus pneumoniae. About 20–25% of people that have strep pneumo are going to be resistant to a Zithromax or a Z-Pak. The macrolides actually, because it's a bacteriostatic and it does not work on the cell wall, penicillins and cephalosporins interfere with cell wall synthesis. Therefore, if you try to give them to a person that has an atypical bacterial infection, they won't work. They don't have a cell wall. However, the mycoplasma will respond very nicely to macrolides or tetracyclines. And tetracyclines are great medicines. We use them for acne. We use them for Lyme disease. They tend to work very nicely on a lot of different infections. Sexually transmitted infection, chlamydia, they work very well for that. Again, we almost always use doxycycline now as opposed to tetracycline. We don't give tetracyclines to pregnant women. Interestingly, it's second trimester that it's actually the biggest issue because that's when the bones are forming. So if a woman happens to be on a tetracycline in the first trimester and you get her right off, she's probably not going to have problems. If you give it to a small child, it will actually turn their teeth green. So you definitely don't want to give it to kids less than 8 years old. Usually they've gotten most of their molars and things by the time that they're 8, but it is a medicine that we avoid in kids. Sulfur, as we noted, is a bacteriostatic antibiotic. Bactrim is half sulfur, and the other is something called trimethoprim. It has great coverage for gram negatives. It has moderately good coverage for gram positives, especially MRSA. MRSA tends to respond very nicely to Bactrim. It is interesting. When I first was introduced to MRSA back in the 1980s, the only thing it was sensitive to was vancomycin. And that's because that's the 100 and 200 strains. The 300 and 400 strains, which are really the so-called community-acquired MRSA, tend to be sensitive to a number of different antibiotics, usually tetracyclines, sulfa drugs, and often quinolones as well. Sulfa drugs can cause a nasty rash. People can get really sick. Serum sickness is basically when the rash occurs on all of your internal organs and interferes with internal organ functioning. But it is a medicine that you warn people that if they get a rash, you really should try to get them off as soon as you can. Aminoglycosides are medicines that we really don't use much on an outpatient basis. They're just inpatient medicines, and we really don't use them that much anymore because we tend to have better options to kill gram negatives just because we have to really do dosing. Gentamicin is the most common. That is the correct spelling of gentamicin with 2 I's there, by the way. And so, aminoglycosides, we can use them for topical. They make good eye ointments. There's a couple of other things that they do, but again, there's another video that talks about aminoglycosides. Quinolones. Quinolones are a pretty amazing advance because these are antibiotics that will penetrate most organs very nicely and really allow us to treat people that would have had to go in the hospital years ago. They are great on gram negatives, fairly good on gram positives. Cipro really doesn't get into the lungs at all, talking about tissues that things don't penetrate into. Levaquin and Avelox really are great for getting into the lungs, so we sometimes refer to them as respiratory fluoroquinolones or enhanced fluoroquinolones. But those are good medicines for those types of infections. And so last but not least, here's a list of drugs of the week. Please comment on these on Blackboard. It's a good place to look stuff up. There's no assigned reading, but you really need to look stuff up and you really need to understand it. So find your own resources and review that. The Lean book will also have sections on all of these.